I'll have to try to go back. I don't even know how to do that, but you'll have both of the videos will be up there. Okay. So we're going to start with celiac disease here. And I'm going to start from the beginning. Okay. All right. So celiac is a defect in that intestinal enzyme. It prevents the digestion of that gliadin, or that breakdown of the gluten. And it usually is going to manifest itself with steatorrhea, muscle wasting, failure to gain weight, irritability. Again, we usually see this in the infant around 4 to 6 months, because that's when we start to add in the cereal. Okay. And then that gluten or that protein is found in things like that wheat, that rye, that oat, that barley. So this is why they can't eat those foods. All right, next up is Crohn's and ulcerative colitis. Okay, a couple of main differences between them. All right, for one, Crohn's affects absorption, ulcerative colitis does not. Crohn's typically has no bleeding. Okay, there's usually no blood in the stool. There is with ulcerative colitis. Crohn's is usually going to be a softer stool. So they can have bleeding, but it's not common. And usually the bleeding comes from the fissures that develop there. So here with Crohn's, we're going to have interference with digestion and absorption, and that is in the small intestines, and that can lead to low levels of protein in the blood, or hypoproteinemia, malnutrition, and steatorrhea with those fatty stools. The fistulas here can form as the ulcer erodes through the intestinal wall. The fistulas can be found between the two loops of the intestines, the intestine and the bladder, or the intestine and the skin. Now, ulcerative colitis, that's going to affect the innermost lining of the large intestine. So inflammation usually here is going to start in the rectum and progress its way proximately through the colon. The small intestines is rarely involved, and there's no absorption issue from the nutrients. Because the mucosa and the submucosa are inflamed here, they become edematous, ulcers develop. That's going to interfere with absorption of fluid and electrolytes in the colon, and it can also lead to that bloody, watery stool that you see. So with ulcerative colitis, usually it's going to be in the lower left part of the abdomen, whereas the Crohn's you're going to see in the entire abdominal lining area, usually more on the right side. Any questions on those two? All right, appendicitis. So most common cause is that fecal lift, which is what? Hard poop. That hard poop. This can develop silently. They'll usually have umbilical pain. That's that colon sign, okay, around the belly button. And a lot of times it'll be like a little bit bluish looking there. That's from the inflammation and the stretching of that appendix itself. The pain becomes more severe and localized to the lower right quadrant. Lower right quadrant tenderness usually develops at McBurney's point, which is midway between the umbilicus and the iliac crest. Here you'll have that rebound tenderness. If the rupture happens, likely pain will go away for a little bit. That's a danger. Then that fluid goes into the peritoneal cavity, and they're going to develop peritonitis. So what is going to happen if they develop peritonitis? What symptoms are we going to see?
Tachycardia.
Hypotension.
Okay, rigid board-like abdomen, tachycardia, hypotension. All right. And that's because that peritoneal area doesn't want that bacteria. Remember, bacteria in that appendix. So when it explodes, that's what's going in that intestinal area, in that peritoneal area. All right. And then here is your peritonitis. Okay. This can be from bacteria that affects the appendix, that affects the intestine, that ruptured appendix, intestinal obstruction, or gangrene. This can happen if strangulation occurred there, like from a hernia. Any abdominal surgery, pelvic inflammatory disease, which we talked about yesterday when we were talking about the reproductive system. So they're going to have sudden, severe, generalized abdominal pain, vomiting, dehydration, hypovolemia, low blood pressure. And then that classic signs are that rigid abdomen, the hypotension, the tachycardia. And then that paralytic ileus, which means what? Paralytic
Loss of
ileus,
peristalsis.
loss of peristalsis. So nothing's moving. Gastric cancer. This seems to be a key factor. Smoked foods, nitrates, and nitrites. So people eating those foods are likely to end up with this. There's also genetics. It comes primarily from those mucus glands. It'll be adenocarcinoma most often. You'll have a lesion in that mucosa or submucosa area. Eventually, the tumor can extend into the serosa, spread to the lymph nodes, the liver, the ovaries. It's usually going to be asymptomatic in the early stages. And then prognosis will be poor once it becomes well advanced. So signs and symptoms are going to be unexplained changes in the bowel habits. So altering diarrhea and constipation, bleeding. Usually they'll have occult blood. So what's that mean?
Blood in the stool?
Can you see it?
No.
No, you
Well,
got to test for it with one of those
yeah, with
tests,
a
okay?
microscope.
Frank red blood could happen on or near the surface of the stool, signifying a lesion in the rectum, because remember that bright red blood is going to come from somewhere lower,
Some
right?
low. Mm-hmm.
Okay. Most of the time, they're going to test for CEA, okay, which is a cancer antigen. So there's a test we can do for that. Most of these tumors are going to form from polyps. So whenever they do a colonoscopy on somebody, if they have polyps, they usually take a biopsy. And these are one of the ways that we determine cancer, because it can be a little bit silent here or not recognized right away. If we do the colonoscopy, hopefully we can catch it early. And so they could do the colonoscopy, take a biopsy of the polyp, and determine from there, based on that and your CEA levels, what your risk factors are, or if you may be developing something. So look at the foods that it comes from, those favorite foods. Okay, hot dogs might not be a favorite, but bacon, donuts, French fries, chips, crackers, cookies, fatty, high sugar foods, red meat, low fiber. Mostly in people over 50. So if you're high risk, they'll probably test you around 45. Otherwise, they'll start testing you at around 50. Liver cancer. This is the most common primary tumor of the liver, the hepatocellular carcinoma. It's more common in people that have cirrhosis. It comes from the areas that are served by the hepatic vein, or it can spread along the peritoneal membrane. Usually there'll be mild or general signs, And then as it advances, diagnosis will be made. Sometimes they'll have to get chemo. Any questions about any of that?
About the cancer, is that the cancer where you don't really, it's hard to tell, and then once they find it, it's already in stage 3, stage 4?
With liver cancer, I don't know. I'm not too sure about that. I would think they would find it before that, because if something's happening to the liver, it's going to affect a lot of parts of the body. Let me see what your book says on that. They usually have to undergo, it looks like, pretty significant testing before they can determine that that's actually what it is.
Okay.
It doesn't really say about time frames as far as what the expectations are for finding it. So it's something I would have to do additional research on to tell you. But it's not something I would expect you to be tested on.
Okay, thank you.
I'll see if I can find the answer for that, but it doesn't look like your book really specifies about how quickly it comes on. And it says that it usually happens with cirrhosis. So this person's already going to be going through some other stuff, and they may not realize it. What you're saying may be true, because they may not realize it if they're having the other symptoms, because what's cirrhosis going to do to the liver? It's going to damage it, right? So it's
Yeah.
not going to be working good to begin with. So that might be why it requires so much definitive testing there.
Okay.
Plus, they're going to look for that CEA marker, not just for the liver not working itself, but they're going to also look at that CEA marker. All right. Next, we're going to talk about the kidneys a little bit. We'll see how far we get through this, okay? And then I'm going to be doing some additional tutoring, okay? So anybody that is on the edge, okay? I really would prefer tomorrow. I'm going to have another session. I am going to send it out to everybody, just because I don't want to go through and pick out certain people. But I really would prefer only for people that are really struggling to come tomorrow, because I really need to be able to focus in with them and hopefully get everybody to where they need to be. But I am going to have another session tomorrow morning at 9:30, okay? All right, let's look at the kidneys. So kidneys are supposed to be filtering and reabsorbing in the body the nutrients that we need, and getting rid of those wastes that we don't need. Okay, so you have some blood flow going in there. You have a large artery that's bringing the blood into each kidney. And then you have also tiny vessels that are going to branch off there and go to the nephrons. The nephrons are those workhorses that do the actual filtration process. Okay. And then water and other substances will be forced out of the blood vessels and into those nephrons. So filtration is where the water and the solutes that are smaller than proteins are forced through the capillary walls and into that glomerular capsule. Protein and red blood cells are not part of this process. They will bypass that process of filtration and go into the basement of the membrane there. If you have protein, if you have blood in that urine, then you have a problem with that kidney. Part of the reabsorption process in those tubules is going to take the water, the glucose, the amino acids, and those ions that we need and put them back into the blood so that the body can maintain homeostasis. And then the body's going to also secrete things like hydrogen ions, potassium, creatinine into that filtrate. The filtrate is your urine so that it can be removed from the body so that wastes don't build up. And this is the main reason why people need dialysis, is because their kidneys aren't doing that process of removing the waste and putting the nutrients that they need back into the body. So a lot of nephrons in the body, millions of them. Okay. And that filtration place is going to take process in those nephrons. You have the Bowman's capsule there. It surrounds the capillaries. And that's where your blood supply is. Those were those afferent arterioles are that are bringing in the blood that is going to be filtrated. Okay. And the fluid, the solutes, are going to be filtrated out of that blood and into the space made by that Bowman's capsule. So during that filtration process, we'll have a large volume of fluid, waste, nutrients, and electrolytes that will pass from the blood into the tubule. And there, the body is going to decide what to keep, what to throw away. Again, blood cells and protein are not going to be filtered into the urine unless there's some sort of damage there. So proteins like albumin, okay, albumin's so important. Why? What does that albumin help us do?
I think it got something to do with osmotic pressure.
Correct. And that osmotic pressure holds the blood in the vessels, holds the fluid in the vessels. If you don't have albumin, then that fluid is going to be in the interstitial space and you're going to have fluid. You're going to have edema, okay? Fluid in that area with that you can't actually use. Okay, that albumin is a water magnet. So that is help pulling that fluid back into the vessels once your body sends the nutrients and stuff out. Once it gets all those nutrients, it's going to pull that fluid back in. And that's what that albumin helps to do. Reabsorption is removing the solutes and the water from the tubules and returning them to the blood. A lot of the water, the ions, and mostly all the nutrients are going to be reclaimed for the body to use it. And secretion is moving the solutes from the blood into the tubular area. Okay. And that removes substances that aren't filtered. That helps to kind of fine tune that final process. So that nephron is the basic structural and functional unit. It regulates the water. It regulates the solutes in the blood by filtering it and by reabsorbing what is needed and getting rid of the rest as urine. This is vital in order for you to maintain your blood volume, your blood pressure, and your plasma osmolarity. And it's regulated by the neuroendocrine system and by hormones like antidiuretic hormone, aldosterone, and parathyroid hormone. So therefore, you need to know how those work in the body. All right. So this is just a chart that's walking you through the whole process here. Okay. But you have the production of the filtrate. Then you have reabsorption and secretion of the water and the nutrients. You have further reabsorption here in the loop of Henle. Okay. This is where your diuretics work, like furosemide is right in here. Okay. This is also where your ADH works. And then you have your distal convoluted tube where it secretes things like your ions, your acids, your drugs. Here, reabsorption of water, sodium ions, and calciums take place based on what the body needs. And those hormones are controlling that. Aldosterone and ADH. So aldosterone helps us do what?
Retain sodium and water.
Retain sodium and water, and ADH helps us do what?
Mostly water.
Okay. ADH is just water. Okay. Now, when do these work in the body typically? When do we release aldosterone and ADH? When fluid is low or when fluid is high?
Low.
When fluid is low. Okay, so anytime the kidneys recognize that that low blood flow is coming into those kidneys, it's going to do something about it. And part of that something is releasing these two hormones to help get more water into the body. And then reabsorption of water and reabsorption and secretion of sodium, potassium, hydrogen ions, and bicarb ions happens in those collecting ducts. And then urine is formed. All right, that glomerulus is a large surface area of capillaries, and it's in close contact with the Bowman's capsule. So it helps with that filtration process. That filtration will produce things containing water, glucose, salts, and urea. So what is that thing it produces? That's that urine. And again, those red blood cells, those protein molecules are not able to pass into the tubule. They're too big. So if they are going in there, then we have damage. In those tubules, the reabsorption of those essential nutrients, water, electrolytes takes place. The hormones control the reabsorption, and it also controls the acid-base balance or the pH of the blood. Any other questions on this? I'm going to likely send you guys this slide as long as I don't have anything on here that I'm not allowed to send you. I plan on sending this to you, okay?
Yeah, thank you.
Excuse me?
You think there's anything off that side? Oh my God, listen to my voice. It's literally.
All right, so the major function of the tubules is for reabsorption, all right? And it can be either through active transport or passive. Antidiuretic hormone is going to control the amount of fluid leaving the body in the urine. The ADH promotes the reabsorption of water in the blood. That happens in the distal convoluted tubules and the collecting ducts. It helps conserve fluid when fluid in the body is low, and you have to know this. Aldosterone regulates the salt and the water. It's secreted by the adrenal cortex. What is secreted by the adrenal medulla? They might ask
Cortisol?
you this.
Brain.
They might
No,
ask
is
you
it
this.
epinephrine and norepinephrine?
Epinephrine and norepinephrine. And our adrenal cortex secretes our aldosterone, our cortisol, and our sex hormones. So aldosterone is going to help increase the retention of sodium and water. So you have to understand that that's going to do what to your blood volume?
Increase it.
Increase it. Okay. It also excretes potassium. So all this is going to help your heart and your blood pressure because potassium also has a little bit to do with your blood pressure. Aldosterone can conserve more fluid when there's a fluid deficit in the body. So ADH is going to stimulate retention in the kidneys, less water excreted in the urine. Whenever the body releases ADH, it's going to cause the body to hold water. If we don't have enough ADH, we're going to lose water. And what produces ADH? Where does it come from? Where is it stored at?
The PP gland.
Okay,
Pituitary gland.
posterior pituitary gland. Good. It's also called vasopressin. You need to know that. Then we have renin. Okay, renin is secreted into the blood. When is renin secreted? Okay, think about yourself. What does renin cause? What's it cause? You know this. Causes vasoconstriction, right? You have to know that. If you know that, then you know what would cause it to be released, right? So when would we need vasoconstriction?
When there is hypovolemia.
Okay, when we don't have enough blood flow, when we're not getting fluid out to the tissue, when we're in shock, when the blood pressure is dropping, we need vasoconstriction, right? So whenever there's low blood flow going into the kidneys, that renin is going to be triggered. And that is going to cause the triggering of angiotensinogen 2. That is the vasoconstrictor. But the renin has to be released for that to happen. What else will the trigger of renin cause? So if the body's triggering renin, when is it going to trigger it? When's it going to trigger it, guys? You got to speak this into existence. You want to know it? Speak it into existence. When is the renin going to be triggered?
Doing a fight or flight.
Yeah, I was gonna say that.
When the blood flow going into the kidneys is low.
No.
Anytime the blood flow goes into the kidney is low. So when would that be? When's your blood flow going to be low?
During shock?
Okay, shock. When else?
When
Dehydration?
Okay, dehydration. Any sort of hypotension. Okay.
Be there.
Now, I just said what other things are going to be present when the blood flow is low?
ADH,
ADH and
aldosterone.
Aldosterone.
aldosterone. All right. So anytime we have low flow going into those kidneys, when the blood is high, when the blood volume is high, when we have too much blood flow, what is going to be released?
AMP,
ANP. And where does that come from?
from the heart muscles.
The heart is going to stretch. And that AMP is going to go to the kidneys and tell it what? Because that AMP is a snitch bitch, right? Why do I call it that?
So it inhibits the action of ADH and aldosterone.
It's going to inhibit renin first.
Oh, renin.
Okay. And then ADH and aldosterone as well. Why is the AMP telling? Why are they snitching? Why is the AMP snitching? Our body likes to be in homeostasis.
is it too salty?
Okay, it's too salty and it's too much, right?
Too much blood.
What's that going to do to the heart?
Hypertension.
Make it work harder.
Okay, make it work harder. And if we make the heart work harder, especially if it's sick, what's it going to do?
Go into heart failure?
Go into heart failure. So look at this, how aldosterone is controlling the blood pressure. It's closely linked to renin, angiotensinogen, Okay, it's helping regulate that sodium and that water together with the renin to bring the pressure up. When it's too much, the AMP will be released, go back down to the kidneys, inhibit the renin, inhibit the aldosterone, inhibit the ADH to bring the fluid back down. This is in people where the body's working. The GFR is too high, okay? And substances cannot be reabsorbed quickly. They can be lost in the urine. If the GFR is too low, everything is reabsorbed, including waste. So that can cause a problem. So in kidney failure, the GFR is low. So the body's not removing waste. Control of the GFR can come from adjusting the glomerular capillary blood pressure. There's 3 mechanisms that control that. Renal autoregulation from your body, neural controls, and hormones, which are those renin angiotensin system. So all those things are regulating that filtration process that's going on in those kidneys. They control the glomerular filtration rate, okay? Autoregulation, which makes little adjustments in the diameter of those arterioles that are allowing that flow into the kidneys. Your sympathetic nervous system, which can cause vasoconstriction to the kidneys. And renin, which is going to be secreted whenever the blood flow to the afferent arterioles are reduced. And that's going to cause that renin angiotensin system to kick in there. Atrial natriuretic peptide. Okay, whenever you have too much flow coming back to the heart, that's going to stimulate the heart to stretch and release that AMP. And that's going to stop your body from reabsorbing sodium and water. In order to do that, it has to inhibit the AMP. It will also inhibit that ADH a bit because we want to decrease volume here. Too much coming back to the heart. So your vessels can contract or dilate based on the amount of blood that's flowing in to the kidneys. If the afferent arterioles are dilated, the efferent arterioles are constricted, then that can change the hydrostatic pressure. It can cause it to increase, and that is going to increase your glomerular filtration rate. Okay, you can also have vasodilation in the afferent arterioles. Vasoconstriction in the efferent arteriole. This is going to increase the blood flow in the glomerulus and increase glomerular filtration rate. So vasoconstriction in the afferent arteriole and vasodilation in the efferent will decrease the glomerular filtration rate. So again, you look at what's happening here. What's being constricted, what's being vasodilated, and that's going to tell you how that GFR will either decrease or increase. Any questions on the AMP, the ADH, the renin? All right, incontinence. You should know, what incontinence is. It's that loss of voluntary control of the bladder. Stress incontinence is going to be more common in women. That's caused by increased abdominal pressure. So you sneeze, it creates that pressure. You wet your pants. Overflow is from an incompetent bladder sphincter. So the sphincter's not working right. It's weak. In the elderly, weak detrusor muscles can prevent complete emptying of the bladder, and that can cause emptying and incontinence. And then enuresis, which is involuntary urination, usually in kids over the age of 4. This can be because of developmental delay, sleep patterns, psychosocial. Retention is inability to empty that bladder. It can be accompanied by that overflow incontinence. Sometimes this can happen from spinal cord injuries, anesthesia. You should know the types of incontinence and what the cause is. All right, I think that's all we're going to get to today, Patho. I will send the invite out for tomorrow morning at 9:30.
Okay. Thank you, Miss Loesch.
Thank you, Miss Loesch.
Thank you, Ms.
Thank
Lowe.
you.
Welcome.
Thank you, Professor.
Thank you, Miss
So are we
Lewis.
staying in the same live for the LTR or no?